Hello and welcome to the healthcare debate between the Benjamin Rush Institute and Physicians for a National Health Program. My name is Matt Neal. I'm the president of Advocates for Healthcare Information. We will be moderating this debate. Thank you ahead of time for filling out the surveys. We appreciate it. Just a little bit about our organization. We hope to provide unbiased healthcare information to future physicians, and we'll be having some talks throughout the rest of next year, so look for us then. Our speakers today from PNHP will be Dr. Ewell Scott. He's a Moorhead internist and a PNHP member and activist. And from BRI, Dr. MichaelStrickland, Committee Chair of United Physicians for Surgeons of America. A little bit about the format. We're going to start with 5-minute introductions from each speaker and then 3-minute rebuttals. From there we will field questions with 2-minute answers and a 1-minute rebuttal for each question. And now I'll turn it over to Anish, our moderator today.
So Dr. Scott from PNHP will be leading off with an introduction.
Good morning. Glad to be here. From Moorhead, Kentucky to University of Louisville Medical School. Wonderful place. I've worked at a multi-specialty group practice for the last 40 years, and we have a number of University of Louisville graduates who've been through there and are still there. And we know you're going to be well trained. The Physicians for a National Health Plan has several goals. One, we want health care to be affordable to everybody. We want health care to be the best for everybody. And we want to seek ways to lower the overall cost of health care. We want there to be free choice of a physician for anyone in the nation to see that physician that they want to see. So what do we have now? We have this huge country of ours. It's a wealthy country for the most part. And we have a healthcare system that is twice as expensive as any other healthcare system in the free world. Twice as expensive. And what do we get for that? We get a system that doesn't cover everybody. We get a system that leaves, at this point, 35 million Americans with no insurance, even after the Affordable Care Act. And we get a system that is so inefficient and complex that it costs twice as much. And why does it cost twice as much? It is because of the some 700 to 800 different private health insurance companies in this world, including Humana. What do insurance companies do? They take your premium dollar, they put it in a big pot, and then they take out money to give to your doctor, your hospital, your physical therapist, your massage therapist, your chiropractor, but not before they take out 30% or 25% of the money for their overhead and profit. That's all they do. They don't treat anybody. They don't perform any surgeries. They don't talk to people about their health care, except in ads that cost $1 million a minute at the Super Bowl. So what our position is to change those things so that we reduce the cost, overall cost of health care by eliminating private health insurance companies and having a single payer insurance company. And in this situation, we think the The best time or the best situation would be to have Medicare for everybody. As you know, Medicare is a government-run national health insurance for old people like me. And when you get to be 65, you can get Medicare. You currently pay a Medicare tax. It's small, but you pay it your whole life as you work. So this Medicare is a single-payer system. We know it works, and we wanted to expand it to everybody. Thank you.
Thank you, Dr. Scott and Dr. Strickland.
Okay. Hi, thank you all so much for having me here. It's a real honor and a privilege. I want to say first, I'm not a member of the Benjamin Rush Institute. I got into this when I was talking with Beth Haynes, and she asked me if I would like to address the medical students here. And I didn't know this was a debate until more recently. So I'm not here to try to convince you that single-party payer is not our best option, but I'm certainly not convinced of that either. And so I want to engage in this discussion. But the reason I really wanted to come on down and address you anyway is to let you know about a conference I'm chairing. How do I get this back up here? This conference here, a group of us last year got together and formed a group, United Physicians and Surgeons of America, because we were so fed up and frustrated with not being able to take care of our patients in the way we were trained and the way we know professionally we should. And we started this conference here, which is called Summit at the Summit, a National Grand Rounds on the State of American Medicine. It's being held in Keystone, Colorado in July, in person and also by live interactive webcast. And I want to invite every one of you to participate. In particular, I want to invite the Physicians for National Health Care Plan to send a speaker if you'd like. I was looking at your website, and last night I looked at the debate in Berkeley that Paul Song spoke for you, and I thought, well, maybe I'll go sit with them, about halfway through. In particular, we agree completely on the problems. The current system is an absolute disaster and is unworkable, and we agree completely. Now, as far as the solution, I don't know. I would say Medicare is the worst of the problems at the moment. And so that makes me real concerned that Medicare is not the solution. However, I think maybe Canada, UK, there are systems that may be working well. And I'm open to hearing about that. But I do have one question for the group, and that is, do you support legal private practice in addition to Medicare for all, such as I believe those two countries have, or would that be illegal and everything would have to go through? Because if there is no competition, there's a real problem. As we all know from biology, if you have a population where there's only one genetic line and there's no competition, pretty soon really bad things happen. The current problem in my book, or at least in my experience, began in 2009 with the passage of the HITECH Act. And this invoked the Meaningful Use program for meaningful use of electronic healthcare records. Before that, I had electronic healthcare records in my office that we designed ourselves at a total cost of $15,000 for design, IT help, hardware, and software, and it was magnificent. But it didn't meet these meaningful use criteria that the government put out through Medicare in 2009 Physician satisfaction with their EMRs was 90% before the HITECH Act, and it fell to 30% thereafter. There's a wonderful article on our updates page here from the New York Times in 2013 describing how these tech companies went and lobbied that commission, Meaningful Use Commission, which, by the way, was composed of 23 people. 23 people, 9 of whom were physicians, 2 of them were practicing physicians. One from Harvard, another was a family practitioner. So basically 1 or 2 people who were going to be using this system were in on the design of it. So you have to keep that in mind when you're asking, are these the best people to lead medicine in the future?
Thank you, Dr. Thank you, Dr. Strickland. And now Dr. Scott will have 3 minutes to respond.
Well, I agree 100% with Dr. Strickland's comment about electronic health records. It's right now the jury is still out about electronic medical records, but so far they have not reduced the cost of care. They have made it more complex, and they have made it more cumbersome. And interestingly enough, that's the same experience that banks had when they went to electronic medical records. They found out that it didn't save them money, and it didn't save them time. So I wonder, as Dr. Strickland did, what in the world happened between point A and point B. But nevertheless, we know it's a given fact these days that we have these electronic medical records, and they're supposed to connect us so we can share health information from one doctor to another without having to call up on the phone. Would you please fax me records from Mrs. So-and-so who was in your hospital 6 years ago, and what kind of operation did she have, and what complication? You know, they're supposed to be able to talk to each other. So far, that's not happening. It's not happening. We have to concentrate, though, for a solution that reduces the cost of our care. As a country, we spend 17% of our gross domestic product on health care. Close to $2 trillion. Does anybody know what a trillion is? A trillion is 1,000 billion. So we spend $2 trillion on health care. And the interesting part about this is that most of our money goes through private health insurance companies. And as I said before, they take out 30% and pass the rest on to you. But the private health insurance company gets 33% of that 1.7 trillion, and physicians get 31%. So the health insurance companies are getting more from the health insurance for their own profit than the doctors are, and the hospitals. It makes absolutely no sense. So this has to change. And the way to change it is to go to a single payer where your overhead of a single payer plan would be 2%. 2% rather than 30%. Now you can do the math. Look it up. Take 1.7 billion, or whatever the number was, just take and multiply 0.02 or 0.17. Do it for yourself and see how much money you can save.
I agree absolutely with Dr. Scott that the current insurance situation is totally unworkable and is one of the major sources of the problem. Let me talk a little bit about my direct care practice. I've been in practice for 25 years as an internist in Cincinnati. Much of that I did ER for the first 12 years. Went back and did a little more training and set up a private practice, and it was really wonderful. I had that from 2005 to 2010. It was a traditional practice with third-party payers. And I just couldn't make any money, but everything else was great. And the last year, 2010, our malpractice carrier came in and gave us an award. They said you placed in the top 3 of 877 on-site practice evaluations that we've just completed. But But like I said, I just couldn't make any money under that system, so I took a job at the VA, and that was when my experience with meaningful use and government-directed health care came about. And I'll tell you what, it was a real nightmare. And in January this year, I started in on a direct care practice, which is a simple monthly membership. It's $50, $75, or $100 per month based on age, and everything we can do in the office is included under that price. People can come in as often as they want. We can interact by phone, text, email, Skype. I can go to their home or office. Any tests or procedures that we can do in the office, all completely covered under that price. Anything that we need to get outside of that, we get for our patients at the best cost we possibly can. So we get MRIs next door for $395 cash. That includes the reading. All the rest of the imaging is less than that, down to $100. We get labs for common labs for under $5 to $10. For example, cholesterol panel $6, which we pass on a cost to our patients. The hospital I worked for previously, $300 for cash cholesterol panel. If you want to see how direct care can work, go to this updates page and look at Josh Umber's Atlas MD. He's got a video, and he really just describes beautifully the economics of it. And I'm using his system, Atlas MD, which, by the way, has an electronic health record. And it's really good. I don't like it as well as the one I designed, but it's very good and much, much superior to the government-mandated meaningful use systems.
Thank you, Dr. Strickland. We're going to move on to student questions now. The first one is actually for you, Dr. Strickland.
Okay.
So thank you, everyone, for submitting these questions. We've taken all of them and kind of distilled them into about 7. We'll see how many we can get through today. So the first question for you is on the patient side of care. So how would patient care management change under your proposed system? Talking specifically about availability, access to care, things of that nature.
Well, as far as this direct care model, accessibility is magnificent. Now, mine is very early, and I'm a solo practitioner at this point. I think it really works better if you have a partner. But Josh, I met him at a conference last fall, and I was just getting started on the Summit project, and really liked what he had to say. And then I flew to Wichita and looked at his practice in person before I adopted the model. They have 3 doctors. Each doctor carries a load of 600 patients. They are available 24/7 by phone, text, email, or to come meet in person. So they see, believe it or not, 6 patients a day per doctor in the office. The rest of the time, they're working again electronically with people. We're not against computers. We're definitely for them. We don't want to be held back in our use of them. Josh tells me he grosses $360,000 and his overhead is $120,000. So seeing 6 patients a day and caring for 600, he's making $240,000. The waste of the current system is so unbelievable. That is why it costs so much, and that's why care is restricted, and you can't get in to see your doctor, and you can't find one. And when you do see them, they don't pay attention to you. They have their face in their computer, meeting the demands of their third-party payers. So I agree completely with Dr. Scott that the current system is horrifically wasteful and very dangerous for patients, and we've got to have an alternative.
Thank you, Dr. Strickland. Dr. Scott, same question.
Medicare for all would eliminate the problems of access because it will be affordable. You would be able to see any physician in the country without restriction to networks that most private health insurance companies put you in. And a network is a mechanism to restrict your choice of physician because have negotiated a better deal with the insurance company. So Medicare would really bring us to a level of true competition. In other words, you could go see the doctor of your choice anywhere in this country, and so that means that the service that that physician gives you is based purely on their ability to satisfy you as a patient. It would eliminate the problems of good care, medium care, or poor care.
Dr. Strickland, you have 1 minute to respond.
That's all right. Go ahead.
Well, I guess we agree on the problem. I'm not convinced on the solution, and I do hope that you guys will bring your message to the summit for further debate and education. But I don't know if you've worked at a VA. I worked there part-time before I left my practice and had a good experience. But when I went there full-time, things really changed tremendously. And I had a couple of other employed positions after that. And in each place, they would send the chief medical assistant around to tell the doctors how to practice. This is how much time you'll spend with a patient. This is how you will document it. And this is how you will practice medicine. Now, this person obviously never practiced medicine. And so that's my concern with letting the government take over.
Dr. Scott, a question for you would be, so how would physicians be affected in either proposed system, specifically yours? Specifically, many students are concerned with the rising cost of medical education, the ability to pay for it. You have 2 minutes.
The question is, how would students respond to the cost of what?
Really, how would the physicians be affected under the proposed PNHP system? And really, they're concerned about the rising cost of medical education, the ability to pay it all.
Well, as you know, Medicare currently funds most of your residency programs in hospitals. That's where the money comes from, is Medicare. And Medicare for all would mean no co-pays, no co-insurance, a minimal deductible, if any, so there would be no denying of care to any individual who wanted to see you, unless you were so popular that people were lined up waiting to see you. So Medicare in this situation is absolutely crucial. It removes the barriers to people seeking care. You know, there are 147 million Americans who are what we call the working poor. They work at jobs that pay about the minimum wage. They have no savings. They don't have health insurance. They're caught in a situation where they cannot improve themselves. A illness puts them over the edge. 2 million bankruptcies in this country. 2 million. Every year. 1 million of those bankruptcies is related to the cost of an illness. 1 million. This does not happen in other countries. France, Germany, Denmark, Sweden. It's unheard of. The medical director in Switzerland said, we would be embarrassed if a citizen of ours went bankrupt because of health care costs. And we have 1 million a year. These working poor people are caught, and we need to change that.
Dr. Strickland, the same question.
Well, I don't really have anything to tell you about that. We haven't thought about that, and I really have no answer for that, about the paying for education. I do want to invite the students here to participate in a webcast test that we're running this Thursday. We're going out to Colorado tomorrow, and we'll be there the rest of the week. And if you have any interest, we'd love to web in with you. And maybe someone else would have something educated to say about that.
Thank you. Thank you. Would Dr. Scott like to respond?
Well, I think that there's a question that came up before was, how do we know that the government can do anything right? And I've had a lot of people, as I travel around the state and talk to some people, a fellow will come up and say, you know, the government can't do anything. They can't do anything right. They certainly can't administer a program such as this. Well, I would say just take a look at Medicare right now. It's the least intrusive of all the insurance companies. It has the ability to control costs. It pays on time. There's almost no rejection. And I think they have done a marvelous job, Medicare has. So I have no qualms about turning the entire country over to Medicare. That means that when you're born, you get a Medicare card. When you die, you lose it.
Thank you. Dr. Strickland, the question for you. The audience has expressed concerns about quantity-based care. This kind of waste of unnecessary care and procedures consumes a great deal of time and money. We would like to know what kind of strategies your system has in place to deal with this waste and increase efficiency.
Well, that's a good question. This direct care model I'm under, one thing I really like about it is that I think it encourages and promotes quality care by the physician. First of all, the better care that I give my patients, the more I make per unit of work. So if I take good care of my patients during the week, then I'm not up there at night or on the weekends and seeing them unnecessary times. The procedures that we do in the office, and Josh does ultrasound and DEXA and more procedures than I do, but those are all included for free, so he has no incentive whatsoever to overprescribe them. Again, with the labs, he's passing those on at cost with a small draw fee. So again, no incentive for him to overprescribe.
Thank you. Same question. Same question, Dr. Scott.
The question is, how do we reduce some of the perhaps over-treatment, over-diagnostic tests that currently is being done? Many studies have shown that. The populations with the most wealthy patients also spend the most money on health care currently. I think a national system where all the physicians were in the same boat, so to speak, it would be a wonderful way to track this sort of information and to make decisions about what needed to be done. Like years ago, before CT scans and MRIs, we worked in the hospital emergency room. We didn't have that available. People came in, got treated, went home, got admitted to the hospital without a CT scan and without an MRI. I work in a small hospital in eastern Kentucky, and they do 35 to 40 CT scans every day. Now, are all of those necessary? No, they're not. I don't see that care has been changed much. So we have to come to grips with this technology because the costs of that are huge. CAT scan, what does it cost? $1,500? $2,000? Where a good clinical examination can solve the problem for $50. So I agree 100%, but a universal system would allow us to look at these things and put out standards and guidelines to say, look, the same thing happened early in my career. If you worked in the I had to work in the ER when I first went to Moorhead because all the doctors did. We had ophthalmologists working in the emergency room as primary care physicians. Talk about a circus. You're supposed to laugh. But anyway, the rule of thumb, the guidelines, if you have a child come in and hit his head, you need to do a skull series, not an MRI or a CAT scan, but an X-ray. So every child that came in who had bumped his head, he got skull X-rays. 2 views here, how they did it. Waters view, whatever the hell that is. And so then somebody looked at it, and they said, how many of these children really need skull X-rays? And the answer came back, about 1%, but only if they lost consciousness. So it really changed the way we approached healthcare trauma in small children. We didn't feel the pressure to do a skull X-ray after that paper came out. So that's a good way to show that science has helped change our clinical procedure.
Thank you. Would you like to respond? Okay, we're going to move on to the next question. So we would like to discuss the long-term integration of your proposed systems, how they would integrate over time, how the time frame really is what we're looking at. This question is specifically fielded for Dr. Scott, I believe.
I think it would be reasonably simple to convert our current system into Medicare for all. We currently introduce about 1 million people to Medicare each year anyway. We know how to do that. We can do that. One physician, Marcia Angle, who was the editor-in-chief of the New England Medical Journal for years and years, her recent article by her said, why don't we do it this way, folks? And she's firmly a single-payer person. She said, why don't we lower the limits of people who get health care under Medicare by doing one new decade every year. So next year we would let people 55 and older select to enter Medicare. The next year we would let people 45 and over, and so on until you get the entire country covered with minimal disruption. So I think that it's just purely reasonable to suspect that this could be done. Now, what are we going to do with all the people who work for insurance companies now, if we do eliminate private health insurance companies? Well, you got to think of all this money that's going to be freed up when we don't have health insurance companies. $400 billion a year? That much money every year will allow every student in this country to go to college for free. The entire state budget of Kentucky is $9 billion. Kentucky's share of that would be $9 billion. So we're talking about huge amounts of money. That money can go back to education, it can go back in infrastructure, building roads, repairing potholes, educating you guys. Medical school would probably be free, and you get in only because you're good enough.
Thank you, Dr. Scott. Dr. Strickland, same question.
Well, I think direct patient care can be worked in immediately. It's you open an office, let people know you're there, and off you go. We are not opposed to, again, this government role in medicine. I do think that there should be a place for private insurance as well. My understanding in Canada and Britain is you have this government system where everybody can go, but if you don't like it, you're having to wait too long, whatever, you have a choice. You can go private, you can get private insurance to cover that, or you can pay out of pocket. Insurance has no role whatsoever in routine care, any more than you have your auto insurance try to pay for your gas and your oil changes. If you can imagine what a nightmare that would be and how expensive it would be, then you understand how the current system works. But what I don't want to see is where there's only the federal government is the only alternative and no one has an alternative. Remember, if you're not free, you're not American. And if you're not at the table, you're on the menu. So I hope your generation will not make the mistake that our generation did, and that is saying, well, we're just going to focus on the medicine and let somebody else do all this other stuff, because believe me, they will do it. They'll do it right to you, and that's what they're doing. Medicine does not have an overall voice now. The AMA has abdicated that role. A few decades ago, 75% of American doctors were members. Now it's around 15%. So that's what we're trying to do with this summit, is to call all organizations and physicians together who have an interest. And by the way, Summit and UPSA has one and one only position, a single position, and that is that physicians who have trained 7 to 12 years or more to do this job must not be told by those who have not done that training how to practice medicine. That's our only position. If you agree with that, we hope you will participate with us in finding solutions.
Dr. Scott, you have 1 minute to respond.
I agree completely with Dr. Strickland's comments in that I just want to make a couple of comments about the VA system. We're not talking about the VA system when we're talking about Medicare. We're talking about a government-run health insurance company. The VA is a government agency created to take care of our veterans at no cost to them. And they employ physicians, and they have different rules. And they don't use Medicare either. But private physicians use Medicare.
Thank you, Dr. Scott.
Is there a response to that or no?
That was the response, actually.
Oh, okay. I just wanted to say the VA, actually, I was surprised to learn this. They do bill Medicare insurance just like every other hospital, and they have the same constraints.
My mistake.
So the next question to you, Dr. Strickland, would be specifically about Medicare. The Washington Times has reported that 5% of Medicaid enrollees account for nearly half of program spending each year. How would your system address this issue?
That's interesting. I did read that 1% of the population accounts for 1/4 of the healthcare spending, and 5% accounts for half of that. And that tells you right there that healthcare for the vast majority of Americans is actually affordable. I think in the direct care model, you just have the two principals talking eye to eye, face to face. And so you don't have the opportunity for all this boondoggle and inflation, and when you have somebody off 1,000 miles away and 10 years ago making the rules and setting the prices, then that's where that kind of thing comes in. But the direct care, at least for the lower end, the routine, the common, not only for primary care, there are specialists doing it. There's a guy, Keith Smith, in Oklahoma City. He's been featured on the national news. He has a big outpatient or a freestanding surgical center, and they do cash surgeries. I had a patient the other day with a complete rotator tear. He didn't have insurance. I asked around Cincinnati for cash price for repair, $30,000. Keith Smith would do it for $6,300. So.
Dr. Scott, same question.
Repeat the question.
The Washington Times has reported that 5% of enrollees account for nearly half of the spending, where 1% is actually 25%. How would your system address this issue?
Well, I'm not sure I believe that. The Washington Times is a questionable source. But anyway, the Medicaid expansion that Kentucky did has been beneficial to my hospital. Medicaid is for poor people. It doesn't pay as well as Medicare, and hospitals generally don't like it because they say it's less than the cost of care. But the cost of care is a funny number. It's a made-up number. When you are charged $5 for a Tylenol tablet or $50 for a Band-Aid during your hospital stay, then those are funny numbers. So I'm not sure that we're getting the correct information here. I think if we had the one system that could do that altogether, that this problem would be eliminated. But I would like to say, can I make another comment about another topic?
You have 1 minute.
1 minute. Man, he's tough, isn't he? I'm going to get your address. Yeah. Anyway, what happens to people who don't have health care? Insurance. They just float along. It doesn't really matter to them. They get good care eventually. What? Well, they die early. They die early, or they go bankrupt. One of the two. Die early or go bankrupt. 66,000 Americans every year die prematurely because they do not have access to affordable medical care. Those facts there's no dispute about those numbers. Now that happens in other countries too, but we shouldn't allow it to happen in this country.
Dr. Strickland, you have 1 minute to respond.
Could you repeat the question?
Sorry, we're actually on a question.
Okay, all right.
We're going to switch the topic over to increased ER visits and primary care shortage. So it was just recently noted that ER visits have gone up contrary to expectations under the Affordable Care Act. This has been blamed on the shortage of primary care physicians for the newly insured. How would your system address the shortage or this problem in general?
Very interesting question. I was introduced to somebody the other day, or to a site, Ideal Medical Practice, and the doctor there was saying how he was talking with the CFO of the hospital and asking, why is it so difficult to get into our primary care clinics, see the primary care docs? He said they get into the ER all the time, but I can treat them more effectively and much cheaper in the primary care clinic. And the CFO said, look, when they come to see you, the hospital gets $50. When they go to the ER, we get an average of $450. I need you to stop doing what you're trying to do. That is, stop trying to get people into the primary care clinic where they can be treated efficiently at lower cost. So, you know, when I worked at the VA and I heard on the news many times that there's a physician shortage at the VA, that physician shortage overall, especially primary care. And I wrote to John Boehner, here's the problem. In fact, I have a letter to the VA secretary right here, which I'll leave here with some flyers. You might read, but I said, Mr. Boehner, the problem here is not money, is not lack of money. The problem is too much money. The problem is this meaningful use money that's encouraging these hospital administrators and owners to force the doctors into becoming box-clicking data gatherers rather than thinking physicians. Well, 2 weeks later, he came out and announced that they had passed a $17 billion increased funding for the VA to address the physician shortage. As I said in my letter to the VA secretary, the problem is not that we're being underpaid. My salary was fine. The problem is physicians were totally disrespected. and treated poorly. And they had the chief medical assistants telling the doctors how to practice. And that happens everywhere in America nowadays because of Medicare. So the doctors have to have, no matter who's paying for it, physicians must control the practice of medicine, must have a central voice. Whether it's government, private insurance, direct primary care, trained people must be at the table when you're deciding how medicine's going to be practiced.
Thank you. Dr. Scott, same question?
Well, I certainly agree that the physicians need to be in charge of the medical care. And I think under a single payer plan where you're assured that all of your patients can pay for your services, that anybody who comes to see you is not going to be saddled with incredible debt, that would take care of that problem. And if you're a private physician, that's great. You'll still take Medicare. Most people who take Medicare are private physicians in some way or another, right today. So I don't think that should be a problem.
You have 1 minute to respond.
Dr. Scott, do you practice with a meaningful use compliant electronic health care record?
I'm retired
Oh, yeah. When did you retire, if I might ask?
about 4 years ago. So I got in under the line.
Right. You know, the problem for me began, like I said, with the implementation of the Meaningful Use Program. I've been in practice 25 years. The first third of that, my impression was at least that Medicare didn't pay quite as well as the private insurers, but it was okay. And then about the middle third, it seemed like maybe Medicare was the best of the choices. But once that meaningful use hit the fan, I mean, I told you my practice was awarded for being in the top 877. I went to work for the VA and then for a private hospital where I'd started 25 years ago, and I thought, well, here will be a harbor in the storm. And it was exactly the same, and it's because of that meaningful use program, that government money telling this is how we want doctors to code and document their charts. And after a year there, I still could not do a quality H&P. I thought, here I am, a 25-year physician who was at the top of his game a couple of years ago, and after a year here, I cannot do an H&P. I'll tell you, I thought many times, this was all scripts, EHR, that we were forced to use. I thought, I would not hardly be more offended if they gave me a bag of dog shit and a quill pen to document my encounters, because at least then I could know how to do it, you know, even if it'd be ugly and smelly. If you look at that article from the Times on our updates page, you'll see that Allscripts was a major lobbyist for the Meaningful Use program, got Congress to appropriate $25 billion, told everybody, told all the hospital administrators, let's come and get it. And their profits more than doubled the next year by $1.4 billion. But when I called them and said, I can't take care of my patients with your system, no response.
We're running a little short on time here, so we're going to jump ahead to the closing statements. Dr. Strickland, you'll have 3 minutes, and Dr. Scott will close it out with another 3 minutes.
Okay. Great. Well, again, thank you all so much. It's a real privilege to be here, and I really enjoyed hearing what you guys have to say. I want to pass along the best advice I got in medical school. Beginning of the third year, I had done a general medicine rotation, general surgery, and now I was on plastic surgery, first day maybe. We were walking down the hall with the attending, just he and I, and he said, well, we're going to see a kid and his mother, and the chief complaint is having trouble speaking. He said, Mike, what is required for speech? And I got all nervous instantly and started fumbling, trying to think of brain areas and the names of the pathways and so forth, and he let me fumble for a moment, and then he said, stop. Son, we operate on the KISS principle around here. Do you know what that is? No. Keep it simple, stupid. He said, in order to speak, you need a brain and neural pathways to send a signal. You need lungs to move the air. You need vocal cords and the mouth to shape the air. Now, which is the problem in this kid? And the kid had a cleft palate. But I mean, that was amazing to me, because for 2 years and 3 months, I had just had this morass of information, just drowning in it and not been able to make sense of it. And his comment just sparked this wave of crystallization that slowly just spread out, and it was beautiful, and it became magnificent, and it's still going on today. And so I would say, when you're trying to figure out how to solve the healthcare debacle, think the same way. Keep it simple. You know, the old saying, how do you eat an elephant? One bite at a time. Genius is E equals MC squared. Very simple, very powerful. A child can begin to understand it, and yet it changes our entire understanding of the universe. Genius is not 130,000 pages of Medicare regulations, which is what we have now, which is almost twice the total number of pages of regulations in the entire IRS tax code. So I have no problem with the single-party payer system, but I understand that Hillary Clinton said in the 1990s when the first healthcare reform came about, and by the way, I supported healthcare reform. I knew the system was bad for my patients. I didn't know how bad it could get for me, but maybe that was necessary to get the doctors off their butts and involved. But I understand that she said, we don't want the doctors to be involved in healthcare reform, they'll just screw it up. Now, I was really mad when I heard that. I've never been a Hillary basher, but I could be one if that's true. I heard that from 2 different physicians, but I was never able to find that quote. But I know one of the physicians' organizations sued in the 90s because they weren't allowed into the hearings. But what I'm saying is, if we go to a single-party payer or whatever system we have, be sure you have a seat at the table if you don't want to be on the menu.
Thank you, Dr. Strickland. Dr. Scott, 3 minutes for closing.
I think we need to understand what single payer is about and what the Affordable Care Act is not about. The Affordable Care Act, just enacted 3 years ago, is built on enhancing private health insurance companies. Private health insurance companies' profits have doubled since the Affordable Care Act came to being. The profits of pharmacies have doubled. Pharmacy companies have doubled since the Affordable Care Act came in, because the government money is going to private insurance companies to buy insurance from them, right? A single payer plan with Medicare would abolish private health insurance companies. They would no longer exist. So they would not be allowed to take the 30% off of the top. And the middleman would no longer be able to take more money out of the system than the providers, which is what happens today. So they need to be eliminated. And we need to treat all Americans with dignity and affordable health care.
All right, let's thank our guests for coming in to speak with us today.